Hello, I'm Beth Warren, and I'm a pediatric hematologist at the University of Colorado and at Children's Hospital Colorado, and I specialize in bleeding and clotting disorders. And this is my mentor.
Hi, I'm Marilyn Manco-Johnson, also a pediatric hematologist, and I've worked in hemophilia through the University of Colorado and at the Children's Hospital Colorado since 1974.
And I was born in 1979, so I'm really glad to be able to learn about hemophilia from you, because I've missed a lot of years of important hemophilia history. Persons with congenital hemophilia have low or missing clotting factor levels. Often the first thing that comes to mind is intracranial hemorrhage, surgical bleeding, nosebleeds. Those are definitely problematic, but a more consistent problem is joint and muscle bleeding. Joint bleeding can cause long-term joint damage, arthritis, and chronic pain. So if you're missing a protein, no problem, just replace it. Prophylaxis in hemophilia is the prevention of joint disease by replacing the missing clotting factor. But the problem with that is that it has to be given directly into the vein. It can't be ingested into the stomach. Just for purposes of discussion, we talked about both factor 8 and factor 9, but we're going to focus on factor 8 because it's a little more common and most of the studies are done in that. So factor 8 degrades fairly quickly after you give it. Normal factor 8 level is 50 to 150%. And then it's completely out of your system after about 48 hours after infusing it. This is particularly problematic in young kids who have tiny veins. So many kids end up needing Metaports so that they can get regular factor replacement. And Metaport replacement means they have surgery and infection risk. The development of safe and effective factor products has also been challenging.
Well, before World War II, individuals with hemophilia had no access to any treatment, and they were generally in a wheelchair by age 10 and often died before the age of 20. The first plasma concentrate, which could bring these factor levels into the blood, were actually developed in World War II by the U.S. for battle injuries, and they were quickly used for bleeding disorders also. Treatment options slowly improved until the 1970s, when freeze-dried factor concentrates were widely available and allowed for more accessible treatment of hemophilia. People could actually be treated by themselves in their own home rather than having to come to the hospital. Shortly thereafter, it was realized that these products, collected from tens of thousands of donors, transmitted viruses including hepatitis and HIV. Although viral inactivation methods were quickly developed, the HIV and hepatitis epidemic spurred the development of recombinant engineered factor 8. A clinical trial to prevent joint disease in hemophilia was only possible after we had a safe recombinant protein to give to these vulnerable babies.
Could you tell us more about what life was like in the 1990s? From my perspective, which is only the past few decades, most patients with hemophilia are on really good prophylaxis. They come in once or twice a year for a bleed, and I imagine that's pretty different from how it was in the 1990s. Can you tell us more?
That's a good question. The 1990s were a very exciting time in hemophilia when a very devastated, discouraged patient and provider population finally had reason for hope and optimism after the HIV epidemic. But many questions still remained. It was not possible to give an IV drug to a small infant every other day through the peripheral veins. Metaports are little embedded reservoirs in which the medication can be injected through the skin. And we asked, were they safe? What would be the Metaport-associated cost in hospitalizations, infections, mechanical failures, and thrombosis? Would this cause more inhibitors, which are antibodies produced against factor 8 and one of the major problems in the treatment of factor 8 deficiency? Would it cause psychologic damage to a toddler? How frequent and how much factor was necessary to prevent joint disease? We felt that these questions were critical, but could only be answered in the context of a controlled, consented, randomized clinical trial.
So you designed the joint outcome study,
in which toddlers with severe hemophilia A or factor 8 deficiency were randomized prior to age 2.5, and the average age was 1, to receive either prophylaxis with recombinant factor 8 every other day or enhanced episodic treatment with recombinant factor 8 at the time of bleeding, using treatments that were in higher dose and longer duration than the standard used at the time. The primary outcome of the joint outcome study was evidence of osteochondral damage, which is bone and cartilage damage on MRIs of the ankles, knees, and elbows, because these are the most frequently affected by hemophilia. The joint outcome study showed that by age 6, the relative risk of MRI osteochondral damage for those on the episodic treatment was 6 times that of those on prophylactic treatment. So clearly, prophylaxis was better than episodic treatment by age 6.
So after the results of the JOS were available, everyone was encouraged to switch to prophylactic treatment. And also everyone who was enrolled in the initial joint outcome study was encouraged to enroll in the joint outcome continuation study, which followed patients up to age 18. And about half of the patients agreed to participate in that study. This slide shows the primary outcome, which was the percentage of participants with evidence of osteochondral damage on MRI at age 6, and then again at age 18. At age 6, those on enhanced episodic therapy had 14 times the risk of osteochondral damage compared to those on prophylaxis. And at age 18, the trend continued. The probability of osteochondral damage in the delayed prophylaxis group was 6.3 times that of the early prophylaxis group. Starting prophylaxis in toddlerhood significantly decreased the risk of joint damage compared to starting prophylaxis after age 6. But the percentage of those with osteochondral joint damage increased in both groups. So even kids who had every other day intravenous prophylaxis since before they were 2 had joint damage. This is way less than their parents' and grandparents' generation, but still, we are not able to fully prevent joint damage, and that is extremely frustrating because of all of the work that these families and patients have put into taking their medication. So there are now several new products to make prophylaxis more convenient and possibly more effective. Also, Marilyn, how does it feel to have 25 years of work summarized in one graph?
Feels wonderful because life for people with hemophilia was improved with the data on that one paragraph. One option for more convenient treatment is making longer-acting products in which the factor protein is modified to make it last longer. Now, there are 2 common hemophilias, factor VIII and factor IX. For active children, the least frequent infusions are once per week using factor IX concentrates, which can be extended to have a half-life of up to 90 hours. However, factor VIII half-lives are not long enough in the long-acting products to be given weekly for active children, and they need to be given 3 times a week. However, there is a new promising product in clinical trials.
We also have Emicizumab, which is an engineered antibody that acts in many ways like factor VIII. But since it's an antibody, it's very small and has a long half-life, so it can be given subcutaneously every 1 to 4 weeks, and that is way more convenient than every other day intravenous factor VIII. And it seems to work as well or possibly better. There are a lot of ongoing studies to look at the long-term outcomes.
There are many other products that are in development that prevent bleeding by rebalancing hemostasis. Overall, you get a clot by making thrombin, the key enzyme. And in hemophilia, your clots aren't strong enough because you don't generate thrombin quickly enough, and you don't generate enough thrombin. The other products under development try to increase the amount of thrombin by inhibiting some of the body's natural pathways that regulate or dampen the amount of thrombin. And this makes your clot stronger.
And in November of 2022, the FDA approved the first hemophilia gene therapy treatment. The FDA has approved it, but insurance companies have not yet approved it, so there are still some things being worked out, but this is very promising that a cure for hemophilia is closer and closer.
And with all of that, the future of hemophilia treatment is bright. Thanks to prophylaxis, people with hemophilia can generally lead normal, healthy lives, and research at the Hemophilia and Thrombosis Center at the University of Colorado has played a big role in these advancements.
And we're still going strong. My research is focused on understanding how movement patterns during sports or just in normal life may contribute to joint bleeding, and we're hoping to eventually develop a biomechanical prophylaxis where people can get preventive physical therapy to prevent bleeding. And here are some videos of the kind of data that we're capturing.
So if you have a patient with hemophilia, you want them to start prophylaxis as soon as possible. This is getting a lot logistically easier with new treatments, and most of our kids with hemophilia today don't need central lines. Joint damage can't be repaired, it has to be prevented. In pediatrics, we have to protect the joints until a cure is feasible and available to all ages. In order to start prophylaxis early, hemophilia has to be diagnosed early. If there's a family history of hemophilia, neonatal factor levels can be checked on the cord blood. But remember that the factor VIII and factor IX genes are very fragile, so 30% of people with severe hemophilia are the first in their family to have hemophilia because they have a new mutation. Also, 50% of kids with hemophilia who undergo circumcision don't have bleeding at the time of circumcision. So if you suspect hemophilia, go ahead and test for it, even if you're reassured by no bleeding with circumcision and a negative family history.
Thank you for listening. If you would like to learn more about our work at the Hemophilia and Thrombosis Center or to refer a patient, please contact us at the information on your screen.